Thanks, Tony. And thanks to the Societies for Pediatric Urology for inviting me to moderate this panel and work with two superstars in pediatric urology. I think it's fair to say that the SPU did not waste this crisis. I think Lewis mentioned this earlier, very, very early this morning, but they taught us a lot. The SPU has taught us how you can come out with a very, very positive outcome using the technologies that are available. And hats off go to Mike Ritchie and Tony Herndon, Luis Braga, Emily Johnson, and of course the PRRI team who've been outstanding, flexible, and in the case of Brittany Dior, very, very patient. So it was Steve Koff in one of his brilliant statements who defined urinary tract obstruction as any restriction to the flow of urine that, if left uncorrected, will cause progressive renal deterioration. Brilliant in concept and very, very simple, but very, very difficult to apply. In fact, frustratingly difficult to apply. And the reason that it's so frustratingly difficult to apply is that because we have a multitude of tests to help us define what we think obstruction is and to establish parameters for obstruction. The problem is that it seems that these parameters are equally shared by what seem to be non-obstructed renal units as well. And that begs the question, do we really want to know if an asymptomatic child has hydronephrosis, or is this information that we wish we'd never had? Well, of course, that all depends on who you ask. Well, as I said, we have two heavyweights in pediatric urology to debate the question, can pyeloplasty be used as an outcome measure for UPJ-like obstruction, UPJ-like hydronephrosis? But before I turn it over to our debaters, I want to set a poll of the audience. Now, a couple of rules about this. First of all, make sure that if you're going to ask a question and pose a question that you'd like me to present later, use the Ask button on the chat box, please. And you have to be signed in order to vote, because you will see a little vote box at the bottom as I pose these questions. So I'm going to present my first case now. So this is a simple case of prenatal bilateral hydronephrosis in a boy, and he has a UPJ appearing obstruction with good function and normal left slide. The right kidney shows very slow washout, VCUG is negative. Preliminary ultrasound at 6 months of age shows some SFU grade 4 hydronephrosis on the right and milder hydronephrosis on the left. The left hydronephrosis eventually resolves. As I mentioned, the VCUG is negative. His diuretic renogram, the purple line being the right kidney, shows a 50% shared function, as you can see, but the washout is very, very slow on that right side with a T1 half time of 36 minutes. He remains asymptomatic, and at 18 months of age, and again at 2 years of age, his ultrasounds remain unchanged. So the question I'd like to pose to the audience is, what is your next step? We have 4 choices for you to choose from. Follow-up ultrasound in 6 months, repeat diuretic renogram now at 2 years of age, retrograde pyelogram for diagnostic purposes, and a pyeloplasty with or without a retrograde pyelogram. Now, we're going to give you some time to vote on that. It'll take a few seconds in order to do that, of course, and I'll try and get the results to you before we go on to our next presentation. But in the meantime, what I'll do is I'll ask Armando to answer the question himself and see what he would do in this situation. And then we can see if the audience agrees with Armando. So Armando, what are your thoughts on that particular question? What would you choose to do?
So thank you, Tony. First, I hope that my hair doesn't look like that cartoon that you just put up. Second, so those pictures is a great case because it's going to highlight some of the controversies that we're probably going to go over during this presentation. But with 2 ultrasounds that look very similar within a somewhat long period of time, and an asymptomatic child with initial preserved, if you will, differential function, my tendency would be to continue to monitor with ultrasound. So I would pick another ultrasound in 6 months.
Okay, let's see if I can get the results in the meantime. I'm going to just refresh my screen here to do so. Let's just take a second. Okay. Okay, we're probably pretty close to being ready for results, or no? Here we go. Here we go. So 51%, as you can see, agree with Armando, follow-up ultrasound in 6 months. 37% ask for a repeat diuretic renogram. 2% a diagnostic retrograde pyelogram, and 7% a retrograde pyelogram and a pyeloplasty, or a pyeloplasty with or without a retrograde pyelogram. So with that introduction, Armando, since you have 51% in your favor already, I'll leave the screen to you. I'll stop sharing and you can take it from here.
Okay. Sorry, I'm going backwards here. Anyway, can my slides be seen okay? Can you guys hear me okay?
Yes.
Excellent. So first of all, I would like to say thank you for the opportunity to participate in this panel. Before I go any further, I would like to just take a second to acknowledge the current situation, the unprecedented circumstances that we're living, and hope that everybody is safe and healthy. The ones who've gone through the first wave and have to endure lockdown with high numbers in the community, and also our friends from other parts of the world where the pandemic seems to be hitting right now. And in addition to that, to thank everybody who's here, who's gone out of the way to continue to provide care for our patients, either in person or virtually, despite personal risk. I think that it goes without saying that this is something that speaks highly of us as medical professionals. Let me start with a definition. But by looking at what an outcome is, I think it's fair to say that pyeloplasty is an outcome. So the question at hand here is not so much if it is an outcome, but if it is an adequate outcome. And if we look at surgery as an outcome, not pyeloplasty, but surgery in general, it has been used for many, many years, publications from many parts of the world, and for conditions that are equally or perhaps even more controversial than the management of hydronephrosis. And when we look in particular into hydronephrosis, the number of publications that use pyeloplasty as a primary outcome or as an outcome that is reported in the paper continues to increase. So adequate or not is being used, and there's got to be a reason why. There are a couple of assumptions when we manage so-called UPJO-like or isolated hydronephrosis, which is what I'm going to use as an example for pyeloplasty, obviously, as an outcome. There are two assumptions that we need to consider. Number one is that we can confidently diagnose obstruction, and Tony already mentioned a little bit of this. At the risk of being repetitive, I may touch on that a little bit. And then second is if we do diagnose obstruction, is this obstruction something that will benefit from surgical correction? And there is the obstruction headache, the definition by Koff, very elegant definition. There was a little bit tweaked by Peters in the 90s. Talks about an impediment in the flow of urine that leads to deterioration in your renal function or the potential for renal function. But even though it reads very well on paper, to implement that on everyday practice is dramatically difficult. And the reason for that is obvious. It's because our measurement tools are just not that great. This is an example of a patient that underwent back-to-back within a week DMSA and a Lasix renal scan due to a scheduling error at our hospital. And I want to call to your attention to the wide differences in differential function when you look at one test versus the other, and also when you look at the position of the patient and how that differential function is measured. And this is not new. When Dr. Pipisado was at SickKids, he provided experimental as well as clinical data that suggested that scintigraphy can be misleading in terms of the amount of function based on the position and the degree of dilation of the kidney. So the tools are really not that great. And gives us an opportunity to question, where does this 50% plus 5% or minus 10%, plus or minus 10% come from? Is it truly acceptable to tolerate a change in 5 to 10% of function before we call something obstructed? If there is such a thing as supranormal differential function, or is this just an artifact? And also, where does this number 20 minutes come from? And does it really diagnose obstruction? And unfortunately, as we learn more about this, the answer is probably no, or at the very least, we don't know. I do need to mention that there's promising imaging studies that could help us with this. And it comes to mind the group from Atlanta who has done a lot of work with this. And the issue with MRI is that it's not widely available and it's not commonly used as an outcome or as an indication, sorry, of obstruction. So even though it has potential, it's just not commonly used and we don't have much data on this. So what do you believe in? Do you believe in differential function? Do you believe in T1/2, on sear ultrasounds, on MRI? You believe in nothing. And this is the issue that we have with many providers trying to attack this issue. And the most likely explanation, or one of the most likely explanations of why, when we look at rates of pyeloplasty across the board, this is one study that Caleb published a few years ago, it changes. And this is mostly based on how much you embrace or not so-called conservative management. Going to make a little parenthesis here and acknowledge two giants in our field, and Tony already mentioned Dr. Koff and Mr. Rensley also, that provided a lot of basis for our current management of UPJ and pyeloplasty. There are many other factors that could affect this equation, and I'm just putting them here because I know that Caleb is going to touch on this, and they truly highlight differences when it comes to pyeloplasties between different hospitals or even different providers. Having said that, why do we do surgery? So why would us as pediatric urologists and surgeons take a child to the operating room to do a surgical procedure? And it's either reactive because we're trying to address something that already happened, lost function, got an infection, we're trying to prevent that. But irrespective of that, I wonder if we're truly that different. If when we look at our indications for surgery and what we do surgery, are we that different? And I hope that the answer is no. And don't we aim to treat our patients the same? And I think the answer, hopefully, yes. And can we study and explain variation? And I think the answer to that is definitely yes. And perhaps more importantly, if we don't use pyeloplasty, we need to have a better outcome. And I don't think that there's such a thing. I mean, we can obviously talk about other outcomes, but the perfect outcome when it comes to UPJ, obstruction, and pyeloplasty is at this point, I propose, not very well defined. So despite the fact that they're imperfect tools and that as an outcome it may be somewhat suboptimal, we continue to do it and say that instead of saying that it's not a good outcome, we could use it as an outcome as long as we look at differences. And in the meantime, we also need to consider other perspectives. So when we do surgery, when we do studies that look at pyeloplasty, who are we looking at that outcome? Which perspective are we using to look at that outcome? Certainly, as a researcher and as a surgeon, it's interesting, but let us remember that many times this is an outcome of interest also to our patients, who eventually will probably have a say on, why do you use surgery? And this probably is more pertinent in other procedures such as hypospadias repair, etc. But perhaps most importantly is parents. And let's just leave this room for a second and go to our clinics and meet parents of babies with antenatal hydronephrosis. And a very common question, if not the most common question, is, will my kid need surgery? Do we have to go down that route? And as such, it's an important outcome. And that's the reason why I propose too that we should explore new emerging technologies, machine learning and image analysis, in order to try to see if we can predict who are the patients at higher risk for requiring or for undergoing a surgical intervention. And this is data from our group, and we're trying to validate it, take into account variation from different settings, that says that yes, you can, if you take imaging studies on different variables, predict who are the patients at higher risk for requiring a surgical intervention. There are a few things that I'm certain about. I'm certain that I'm going to have to pay taxes probably for the rest of my life. I'm also certain that I'm going to be wrong many, many, many times. However, I'm going to quote a very smart person, Professor Caleb Nelson, who works at the University of Virginia. And he says to figure out all the steps and make sure they fit together and maybe resemble the problem into a solution. Those are very wise words. And he also may or may not have said, never, ever, ever debate Dr. Caleb P. Nelson, who's probably one of the smartest guys I know and also has a very good Twitter handle. I wish I had gotten it before he did. I'm going to have to try to steal it from him. So maybe to summarize for the sake of discussing further during the question and answer session. Is pyeloplasty optimal? And I would say the answer is definitely not. It's not an optimal outcome. Is it sufficient? At least for now, I would say it's a conditional yes. I don't see anything wrong with using it as an outcome as long as we understand the limitation that is imposed by us using that as an outcome, and knowing that there's variability between centers, between surgeons, potentially between patients, and it could be affected by other factors. I don't think we need to use that as a reason not to use it as an outcome. I think we should use that as a way to look at the outcome in a better way. Ultimately, can and should we do better? And I think the answer to that is absolutely. If you think about why we're here on a Saturday looking at presentations on a computer, why we get out of the house in the middle of a pandemic and go to a hospital every day, is because we want to provide better care. And in order for us to provide better care, we have to do better. And certainly this is an area where we need better outcomes in order to provide better care. Now I'm going to take 2 seconds and remind ourselves that the things that we do today are going to have an impact on our patients many years down the road. And that impact may not be noticeable until we're no longer here, or until we're in a nursing home and we will know about it. And that is the potential impact of our interventions on renal reserve. We're born with a number of nephrons and we need to keep those over time as happy as possible. It is sad, but as we age, the number of nephrons that we have is going to decrease. And there are going to be things that happen, either anatomical or not, that will affect that. And the more insults that we encounter over a lifetime, the worse that kidney function is going to be. A patient that in their 40s goes into renal failure because of something that was or was not done during childhood, it is sad. And is there any evidence that there may be something at play here? And I think the answer to that is yes. If we evaluate a recent paper in the New England Journal looking at the impact of congenital anomalies of the kidney with surgical correction or not, and the subsequent development of renal failure, there's a significant association, and I think is something that we as pediatric urologists should pay closer attention. I hope I stay within my allotted time, and I wanted to finish again by saying thank you to everybody for participating in the forum, for everything that you do. I hope that you and your family are safe. And thank you for Tony and Caleb for allowing me to participate in this panel, and for the SPU also for the opportunity. Thanks.
Great. Armando, thank you very much for a very, very compelling argument, as usual. So let's go back to my slides for just a second here. And not that way. All right. And we'll go down to the second case. There we go. Okay. So before Caleb comes in and gives us his counter argument, let's go through a second case and see what the audience would choose to do in this one. So this is again the case of prenatal hydronephrosis. But in this situation, there's reduced function on the right side with very, very good washout. The left side is normal and the VCUG is negative. So here's a grade 4, SFU grade 4 hydronephrosis of the right kidney noted at 3 months of age. And the washout curves, the circles being the right kidney, showing that the diamonds being the right kidney, diamonds being the right kidney, shows that at 6 months of age, the differential function on the right side is 43%, but the washout is very, very normal at 11 minutes. He remains asymptomatic and has the same ultrasound appearance at a year of age. So here are your choices again, same choices as last time. A, repeat ultrasound in 6 months. B, repeat diuretic renogram. C, retrograde pyelogram for diagnostic purposes. And D, a pyeloplasty with or without a retrograde pyelogram. And while we give you a little bit of time in order to answer that question, I'm going to ask Caleb what he would do in this situation. And then when we have the results, we'll see if you agree with Caleb. So Caleb, do you mind taking the control and going ahead and telling us what you would do in that particular scenario?
Yeah, thanks, Tony. I think that based on just the way the ultrasound looks, as I think Dr. Reddick would tell us, he would say, you know what, that's a surgical case. And I would tend to agree, just based on the appearance. I think the fact that there is somewhat diminished function is an additional factor that compels me to think this is probably going to need surgery. I don't place as much stock in the less impressive drainage parameters. So I think this kid's going to get a pyeloplasty either way. I probably would repeat the renal scan before we did that. I want to know where the differential function is before we go to surgery. But I think we're going to go to surgery.
Great. So thank you very much. I'm waiting. I don't see an option on my screen. Here we go. The results are in, so we're going to publish the results. So 25% of the audience would repeat the ultrasound in 6 months. 49% would repeat the diuretic renogram at this time. 3% would do a retrograde pyelogram for diagnostic purposes. And 21% would do a pyeloplasty with or without a retrograde pyelogram. So we got a pretty split decision on this one, a little bit more controversial as I would have expected. And so I will stop sharing my screen and give Caleb an opportunity to present his argument. Caleb, you have the screen.
Okay, so let me see if I can. All right, hopefully everyone can see this. So thank you, Dr. Caldemone, for moderating this session, and thank you to Luis and Emily for putting together a great meeting, and to all the SPU folks for really, it's remarkable what you've done to put this together. So thank you for doing that, and I really appreciate the chance to participate in this. So I'm going to try to advance my screen. Huh. Okay, I guess it wants me to do it that way. So some disclaimers. These are my opinions, no one else's. I don't have any financial disclosures. And the last one is that everyone likes Armando, which puts me at a real big disadvantage in a debate, but that's the way it is. So the first question is, as Armando alluded to a little bit, why do we use pyeloplasty as an outcome, an endpoint in the first place? Well, I think most of the reasons are pretty obvious. It's a very discrete event. There's a date that it happens. It's easy to find and document in the medical record. It's a yes or no dichotomous outcome. And it's pretty much the only definitive treatment we have for UPJ obstruction. So it's the only surgical endpoint you get to. Furthermore, there's at least a perception that the occurrence of a pyeloplasty is a reliable indicator of a specific phenotype, meaning when we say that kid needs a pyeloplasty, we know what that means. And that's an assumption that I think is less certain, and it's something that we'll challenge here a little bit. So why should we not use pyeloplasty? Because you might say, well, don't we care who gets a pyeloplasty? And yes, of course we care who gets a pyeloplasty, but from a methodologic standpoint, I would argue that we really don't as much. You might say, doesn't it indicate which patients truly have obstruction and which don't? And the answer is probably not, and we'll see why. Undergoing pyeloplasty is really not an objective endpoint, and I'm going to talk a bit about why I think that's so. The reasons we don't really want to use pyeloplasty is that the decision to go to surgery is driven by many clinical and non-clinical factors, and Armando alluded to this. Many of them are not directly related to the clinical condition. And furthermore, there's well-documented variability in the use of pyeloplasty, which suggests that it doesn't really indicate a clinical status, and nor does it really predict overall survival, renal survival, quality of life, functional status, or any of those things. It really just indicates that we decided to do a pyeloplasty. In other words, all these years, we have been jumping to conclusions about pyeloplasty. So this goes back a long ways, all the way back to the beginning of the fetal diagnosis era. And from that time, there's been discussion, debate, discord about what we should be doing. So in the 80s, Dr. King and others proposed that the best treatment for these neonates was to fix it right away, and that was the best way to address neonatal, prenatally diagnosed neonatal hydronephrosis. It only took a few years for others, led of course by Dr. Koff, to say, well, actually that's probably not necessary. Most of these kids do fine if they're watched. And really you shouldn't be operating on many, if any, of these kids. And so that debate continued and has continued to persist over the years. You might say, well, yes, that was in the past, but surely we now agree, we know now what the indications for pyeloplasty should be. And so I thought we might let's look at some of the recent publications looking at this topic. These are cohort studies of patients, children with UPJ obstruction that used pyeloplasty as their endpoint. And we're going to look at what the indications for pyeloplasty were in each of these papers. So here's this big table. Down this side are 6 relatively recently published papers. And this is not to pick on anyone. This is not to point out anyone's flaws or anything like that. These are all well-done papers by really very capable researchers. But look how much variability there is. In terms of the appearance of the parenchyma, only one of these groups used it as an indication for surgery, but one of them did. Now, several groups used the degree of dilation or the change in the degree of dilation as their indication, as one of their indications for surgery. But I've highlighted the indications here that I thought were at least in some ways subjective. And as you can see, there's a lot of subjectivity in terms of whether hydronephrosis really is worsened or not. Now, differential function is another one that most people use. 40% seems to be a very common number that's used, but not everybody. And not everybody uses it at all as an absolute threshold. Similarly, many people use a change in differential function, but different groups use a different threshold for what triggers the surgical treatment. Some people use 5%, some people use 10%. A kid with an 8% change in their function would get a surgery at this site, but would not get a surgery at this site. Drainage parameters, again, they're kind of all over the map in terms of how precise people are when they say what drainage parameter would trigger you to go to surgery. And then there are other factors that several of these papers included, some of which are pretty subjective, some of which are non-clinical at all. The point of all this being that even recently, different papers, when they present the reasons why their subjects went to surgery, which is their endpoint, they use different metrics. So what that means is that when people use pyeloplasty as their endpoint, and then they try to find what factors are predictive of that endpoint, they find that the same factors they're using to decide surgery are the ones that predict the endpoint, which is exactly what you'd expect. So let's just look at one series from 2015. We don't need to point out exactly which one, but it's a single center series. They used pyeloplasty as their endpoint. And what they listed as their indications for surgery are the things you might expect: functional changes, hydronephrosis worsening, cortical thickness measures, and obstruction on the drainage curve. And what factors did they find predicted their endpoint? Well, it was function, it was hydronephrosis, and it was cortical thickness. Again, that's exactly what you might expect. So this creates this situation where we have kind of a circular logic of using surgery as the endpoint. We decide a priori, usually with reasonable justification, to use certain factors to make surgical decisions. We obviously have to use something to decide who needs surgery and who doesn't. We then study that, and we find that the factors that we were using are associated with surgery for UTD or hydronephrosis. We then conclude that these specific predictors are very useful to decide who needs surgery for UTD, because we found they were associated with our endpoint. And then you're pretty much back where you started. These factors, same factors, continue to guide our treatment, despite not actually being associated with the long-term outcomes we're most interested in, but rather with the surgical intervention that occurred. Now, beyond that problem of circular logic, there is also, as Armando alluded to, there's this unwarranted variation issue. This is well documented in medicine as a whole, in surgery and urology over the past couple decades. Use of surgical intervention, and all therapy really, varies by a number of factors that have very little to do with the clinical situation. It might vary by race, ethnicity, or geographic region. Might vary by socioeconomic factors, status, insurance status. It might vary over time in that, as Armando alluded to, our indications for surgery during one time period might be different from in another time period. Now, there's extensive evidence for this in prostate cancer, for example. There's a whole literature looking at this in that field, looking at variable use of the different treatments. But we shouldn't imagine that we are somehow not susceptible to the same factors that contribute to this. So the folks in Colorado looked at the FIS database a couple of years back. They almost 4,500 patients in FIS who underwent pyeloplasty. All of these patients did undergo surgery, but what they looked at was the timing of that surgery. And what they found was that a number of these factors were associated with timing of pyeloplasty, even though they don't have much to do with the clinical condition. We, in our group, looked at this a couple times, once using the kids inpatient database, again, kids with pyeloplasty, and found that timing of surgery varied by race as well as a number of other factors. And then we looked at our own internal cohort and essentially found the same thing. Now, while all of these patients actually did undergo pyeloplasty, I think it's a reasonable hypothesis that the same non-clinical factors that influenced timing of surgery might also influence whether or not someone gets surgery in the first place. Beyond that, we know, as we saw just in the last presentation, that pyeloplasty is becoming less common. And our fellow Bryony Varda published just a couple of years ago this study looking at the use of pyeloplasty overall, and found that the rate of pyeloplasty has decreased by 7% annually over the past 15 years or so. And this is that same figure that Armando showed. And, there's a pretty dramatic decline in the incidence of this procedure over this time period. How do we explain decreasing incidence of a surgical procedure unless the thresholds for intervention are changing, at least in some places or by some doctors? As far as we know, the underlying disease hasn't changed. As far as we know, prenatal hydro rates are unchanged. And other than the introduction of robotic surgery, which may have shifted surgical decision-making in some ways, we haven't really developed new diagnostics or treatments. The treatment is still basically the same. So that leads us to the idea that this is a complex decision-making process. There are many, many factors that contribute to surgical decision-making. Armando actually essentially had the same slide. I just put all the things in horizontal form, but we're going to review them just to point out how complicated this decision-making is. We use drainage times and differential function and the change in the differential function. Some people use cortical transit time. Some people use whether or not there was spontaneous drainage or the post-Lasix drainage. Some people base it on the ultrasound appearance of a scoring system such as UTD or SFU. Some people use those individual parameters like AP diameter, calyceal dilation. Some people put a lot of stock in the thinning of the cortex or the appearance of the cortex. There's the function of the contralateral kidney that we have to consider. There's also the question of whether the child has had a UTI or not. That often will influence the decision to fix a patient with hydronephrosis, and it's almost never included in the list of indications. There is the question of a solitary kidney, of course, which will maybe change your threshold for intervention. The presence of stones might influence whether or not you decide to go to surgery, again, rarely discussed. There's comorbid conditions, which of course influence whether you think it's safe or even helpful to go to the operating room to fix a UPJ obstruction. And then, of course, there's a whole bunch of social and family issues that have to do with patient preference, anxiety, the issues of whether a family is just by philosophy, whether they're more proactive or whether they're more conservative. And these have, as we all know, enormous influence on whether or not we decide to schedule a case. And then we might not like to think about it much, but there are other factors that play a role. And I don't think pediatric urologists are immune from behavioral economics or incentives, and we face productivity expectations and OR time requirements and financial incentives. And even if those aren't conscious factors in our decision making. They're still there, and we'd be naive to think they don't have some impact. So, as Armando pointed out, if you're not going to use pyeloplasty as your endpoint, what's the alternative? And he's right. There is no great alternative currently. What we need is to figure out what discrete and objective metrics are available to determine whether a patient meets a particular definition for a threshold of pathology. It might be a composition of several different things. But the idea is that it should be discrete and objective. It might be ultrasound parameters as listed here. It might be functional renal scan results. It might be symptoms of flank pain or other clinical factors. But the main idea, I think, is that it is based on a threshold of pathology. It's not based on treatment. So if you report which patients meet these specific and reproducible anatomic and functional parameters, it's regardless of whether the surgery occurred or not. And even if different centers didn't necessarily use the same thresholds to make their decisions, by reporting these specific and reproducible parameters, you would still be able to potentially compare results and outcomes regardless of whether surgery occurred or not. Now, I think to do this, you would need consensus. You would need to have a consensus meeting. You would need to get a group together of our specialty, and probably it would be helpful to have members of other specialties, nephrology, radiology, surgical outcomes specialists, to try to come up with a panel or a composite indicator of the pathology that we care about. But I think it could be done, and I think it would be an improvement over using surgical intervention for the outcome. So I would like to thank my debate opponent, Dr. Lorenzo. A former colleague of mine used to say how much she liked to see Dr. Lorenzo at the urology meetings because he's so handsome. And I'm not a very good judge of these things, but on consideration of that, I realized that Armando does kind of look like someone famous, but I could never really put my finger on who it was. So, of course, I went to the internet and I found a website where it will tell you what celebrity you look like. So I put handsome Armando's picture into the website, and according to the internet, Armando most resembles Keanu Reeves and Lionel Messi. So congratulations, Armando. You are in very good company. And thank you again for participating in this debate.
Caleb, wonderful presentation, very elegant as usual, and a dramatic finish also. I'm going to share my screen if I can again. There we go. Okay, and let's just scroll down a little bit. So because this wasn't mentioned, I thought I would share with you a couple of recent papers that have piqued my interest about whether or not we should be considering some type of scoring system for patients with hydronephrosis, especially those that presented prenatally. The first one was published in 2019 in the Journal of Pediatric Urology by Babu and co-workers, and he developed a hydronephrosis severity score in which he used differential renal function, drainage curve, and hydronephrosis grade, and grouped those scores together to try and predict the likelihood of going on to develop renal deterioration. And then the second was by Luis Braga and his group, and this will be published shortly in Frontiers, already accepted for publication, in which he's using a pyeloplasty prediction score. The difference between this and the Babu study is that instead of using the differential renal function and the renal scan results, we're more relying on the ultrasound findings, combining SFU grade, AP diameter, and a baseline of differential function, renal length between the ipsilateral kidney and the contralateral kidney, as you can see here. And those that fall in a greater than 8 category on using each of those variables on a 0 to 4 system would be more likely to require going on to pyeloplasty, such that if you saw a patient such as this at 2 months of age with grade 3 hydronephrosis and had a dramatic increase and used all the other parameters as well between 2 months of age and 9 months of age, one would see an increase in the pyeloplasty predictive score, which would push you towards correction. So I put these out there because these may come up in our question and answer period. And with that, of course, I will go to the question and answer period. And there have been several questions that have been posed. So I will alternate between Armando and Caleb to see if we can get some of these questions answered in the final few minutes that we have available. So Armando, one question that came up, particularly regarding the results on a renal scan, is how do you interpret hyperfunction or superfunction on a renal scan? And is that a factor that may push you towards a particular management?
So Tony, that's a great question because it's a very difficult question. I mean, in essence, what we have to consider is that a potentially obstructed system is working better because of hyperfiltration, et cetera. I think that many of those so-called supernormal functions are actually artifacts, that the differential function was not measured at the correct time or was measured appropriately, and that's where this fudge factor of 5 or 10% comes into play. Over the years, and I guess this shows that I've been doing this for longer than I would like to think I have, I look at the curves and the differential function a little bit more, with a little bit more cynicism. I don't know how much I use that value to help me make the decision for surgery. But eventually what ends up happening is that I think the patient declares itself, if not with a nuclear scan, with the progression on different ultrasounds, on serial ultrasounds, et cetera. So I don't know if I would use supernormal function as a significant factor to lead me to correct. It also won't stop me from considering correction if I think the hydronephrosis is getting worse. I hope that was not too wishy-washy, but.
Thank you. Caleb, what are your thoughts on supernormal function? Good, bad, or indifferent?
Yeah, it's one of those very confusing features of nuclear medicine, one of the many, and I have yet to really hear a convincing explanation from anyone as to what it represents. I tend to agree with Armando that if I had to guess, I would guess it's probably some kind of artifact, possibly related to the dilation, but I just don't know, and I don't put much stock in it. What I generally assume is that if the function is supranormal, then at least it's not decreased. And so if I had to have a function measure, I would rather have it be supranormal than decreased. And so, and it doesn't tend to trigger me to push more toward a surgical intervention. I think what it also indicates is the need for a contralateral function agnostic measure of the function of the hydronephrotic kidney. In other words, we don't really want to know what percentage of the total the abnormal kidney is. What we want to know is what function does the kidney itself have. It would be really nice if we had an absolute measure of the function of that kidney, irrespective of what's going on the other side. And we don't have that, at least not yet.
Very good. Another question that comes up, and we'll start with Caleb on this next question first, is when do you decide to repeat the renogram, if at all, in an asymptomatic patient who has persistent hydronephrosis?
Yeah, I think it's a good question, and I think it's something that we all, there's no cookbook for this, so we all vary tremendously in how we approach it. My practice typically, with not really based on great evidence, is that if the ultrasound worsens, that will usually trigger a repeat renal scan in my practice, or if the even if the ultrasound does not worsen, but the degree of dilation is substantial and it has persisted for a while. And if it's been a while since the last renal scan, say a year or maybe a year and a half, and the hydro is still very significant, then those are the ones where I might decide, discuss it with the family and say, maybe we should repeat the renal scan. Again, it's to reassure ourselves that the function doesn't seem to be decreasing silently. But again, that's not really based on any real evidence. It's just seems logical to me.
Very good. Armando, your thoughts on that question, please.
I was hoping you would skip me and go to the next question. I
The
struggle
next
with this a
question,
lot.
next question is harder. So
I struggle with this a lot, and I must admit that I worry about radiation exposure, perhaps not based on solid basis, but I think that any radiation to a baby or a young child, we should take seriously. I tend to, if I look at an ultrasound, there's worsening hydro or there's lack of improvement, I tend to consider going ahead with a pyeloplasty without the security blanket of a nuclear scan. More so because, again, the differential function on the T1/2 on a nuclear scan, unless it's completely normal, and even then, I worry that it's misleading me. And I find this is anecdotal, but currently infant pyeloplasties in my hands, this is my data, have a less than 5% complication rate, and more than 50% of those patients are going home the same day with an external stent. They don't have a double J that you have to take out. That rivals outcomes from, I don't know, hypospadia surgery, say. So many families that have gone through that, when I go back and ask them, how was your experience? The worst part of the whole adventure was not the surgery, it was the imaging studies that we did that led to the surgery. I would have a hard time putting my child or any child for that matter through a series of nuclear scans if I think that we're going to end up doing surgery anyway. So maybe to summarize, I tend to not repeat the scan if I think I'm going to do surgery. If there's worsening dilation or persistent high-grade dilation, talk to the family, obviously, but that's what I would say, that the surgery may not be that much, may be better than just repeating scans if we're going to end up in the same place.
So, sort of like the argument for doing a reimplant as opposed to repeating a VCUG, correct?
Or deflux or
yeah, exactly. Okay, so I'll stay with you, Armando, for just a second. Do you use, or do your radiologists use cortical transit time off the renograms in a useful way?
They do, but I guess the useful way is the part that I would question. I mean, the numbers over the years have changed. Sometimes you get it, sometimes you don't get it, and the reports are not super consistent all the time. I think the numbers that we use are the classic ones: differential function and the T1/2. And the other thing that they measure at times is the retention. At the end of the scan, they put the kid up and they see how much they retained of the radio tracer. But no, and maybe this is an opportunity to say that this is where you could say that MRI could be of value. You can take and get more information out of MRI, and all of this data, a lot of this data comes from Atlanta, from Andy's publications on the topic. And the issue with MRI is just that it's not widely available, it's expensive. You have to give the kid gadolinium, but perhaps more importantly, you have to put the kid to sleep. And if you're going to put the kid to sleep and potentially end up doing surgery anyway, why not just do the pyeloplasty? If your complication rate's really low and one surgery will deal with the problem, I don't know if I would put the kid through 2 anesthetics just to prove a point.
Caleb, do you have some thoughts on the cortical transit time and or the use of MR urogram in these cases?
Yeah, our radiologists, they do report the cortical transit time as part of the report, and I look at it. I never quite sure what to make of it. It is remarkable how often it is basically the same on both sides, regardless of what else is going on. I find that when the cortical transit time is elevated, that's almost always a situation where the function on that kidney is also diminished. It's pretty unusual to have that as the only indicator of a problem, and so I find that it doesn't usually add a whole lot. But as we saw in my slides, there are a couple of groups routinely use cortical transit time. So I think MRU is tantalizing and it remains just around the corner, but I think it's almost there. Some of the folks here have done remarkable work with the infant MRU, doing the feed and wrap, which avoids the anesthesia requirement. And they're still working on getting the functional measurements worked out, but I think they're almost there. And the ability to report really good anatomy and really good functional data without anesthesia is extremely promising. And Mei Chow in our radiology group has worked long and hard to get that to a place where it's workable. And I think it's going to be an option. It's just not an option everywhere.
Great, thank you, Caleb. I'm going to stick with you for this question that's come up. In our current management paradigm, most would not argue against the pyeloplasty in the face of a significant drop in renal function. But are we waiting too long if we wait for that drop in renal function? And the corollary to that is that drop in renal function recoverable? Complicated question.
Yeah, it is. It's a very difficult question, and I think it's probably correct that if you've waited until the renal function drops, that you waited too long. I think that probably makes sense. I think the problem is until it drops, you don't know that it's going to drop. And short of fixing everyone, what are you going to do until we get the ability to predict that's going to happen before it happens? You don't really have the ability you don't have that crystal ball, as everyone says. So, I think to some extent, once the function drops, it's not like game over. I think there is some evidence that you can preserve the residual function, and there are papers out there showing improvement in function, particularly for very low functioning kidneys with a UPJ obstruction, especially in young infants. If you fix it, you may get an increase in the differential function. Whether that's real or not, I don't know. But I think it's better to fix it at that point than to wait for more worsening.
And Armando, your thoughts on waiting for a drop in function in order to advocate for a pyeloplasty with a family?
So I wish I could copy and paste what Caleb just said. Is brilliant. I completely agree that once you see a decreasing function, even though it may recover a little bit, what you're praying for is not to lose anymore. I guess this makes me think of, for example, cases where you have bilateral high-grade UPJs or a UPJ in a solitary kidney. And as Caleb mentioned in his talk, we tend to be more aggressive with those because the stakes are a lot higher, right? We're worried that if we lose that function, the child is going to be in trouble. So let's put that in a bigger perspective and say that by delaying it, the kid may not go into renal failure by the age of 5, but may go into renal failure at the age of 55, instead of going his whole life or her whole life without needing renal replacement therapy. So yes, that's the reason why I use the differential function less and less and go straight to pyeloplasty many times, just based on degree of hydro, lack of improvement or worsening. And it is a somewhat subjective view of the world, but it's one that is more preventing, more proactive rather than reactive, as I showed in my slide. Maybe let me make a parenthesis here, if I may, with machine learning. One of the reasons why I like machine learning and image analysis is that perhaps we have a tool that, even though these parameters that we're using are somewhat subjective, if we had a tool that would consistently give us the same answer, no matter where in the world you're using it, perhaps that will help us at least standardize which patients we're putting in a category of high risk, intermediate risk, or low risk, and would allow us maybe to compare apples to apples, as was mentioned before during one of the sessions.
So Armando, I'll stick with you for this one. Since you brought up the concept of transition from childhood to adulthood, everyone would agree that there's been a decrease, at least in the last 15 to 20 years, in the number of pyeloplasties that are being done. Are you aware of any evidence to point out that the number of pyeloplasties in adult population is increasing as a result?
Sorry, Tony, I didn't get the last part of that question. Could you repeat it?
So the question is, because there's been a decrease in the number of pyeloplasties that have been performed in children over the past 20 years, has there been evidence of an increase in the number of pyeloplasties being performed in adults? Are we just pushing off the inevitable, in other words, until they become symptomatic as an adult?
Not that I'm aware of. I remember a time where we tried to look at that and see if our graduates were ending up somewhere else in Toronto getting more pyeloplasties. Did not appear to be the case. However, I worry that some of these patients don't end up getting another pyeloplasty, but end up losing differential function or kidney function. And then you don't find out about it until they get into trouble with kidney function. So if 10 or 15 years may not be long enough for that. These outcomes may take 30, 40 years. And that's why I mentioned that we won't be around to know if what we did was right or wrong. But is that fair to our patient? The fact that they're going to outlive us by many, many years. I think maybe it's better to consider having a little bit of foresight and saying, maybe this is a patient that would benefit from surgery before they lose function, because I want them to have as many nephrons as they can for as long as they can.
Very good. Thank you. Caleb, any thoughts on that issue? Are we postponing pyeloplasties and pushing them into adulthood when they become symptomatic?
I suspect we are postponing a few, but I also feel like most of them would show up. I don't think you need to wait 30 or 40 years for them to show up. Some of them, yes, probably it would take that long. But I would suspect that the majority of infants who don't get fixed and yet aren't followed are going to show up sometime sooner than late adulthood with whether it's UTI or stone or just hematuria or some kind of problem that will trigger further workup. And they might be 12 at the time, they might be 15 or 20. Now, that's not to say they may not have lost function. I agree completely. I think Armando's right. If you guess wrong on this, the consequence is loss of the kidney. And if you guess wrong on both sides, the consequence is loss of renal function. So it is a problem that I think warrants a lot of caution and a lot of thinking about, whether we're doing the right thing. Potentially studyable with some of the large databases that look at adults, looking at rates of pyeloplasty in adults using nationally sampled hospital data sets. It's potentially could be looked at, but I'm not aware that anyone has looked at it.
Very good. I'll stick with you, Caleb. We just have a couple more questions to go and just a couple more minutes. So I think timing-wise, we're in good shape. Should we be adopting a risk stratification system for hydronephrosis? And if so, how would you go about doing that?
Well, I think that's essentially what the UTD system is. In fact, it says right on it, high risk, moderate, low risk. So I think that is what that's what it seeks to do, is to categorize both the fetuses and then the newborns or the infants as likely to have as high risk or low risk, whatever you think that means. When we looked at the UTD predictive capacity a couple of years ago, we did find that the UTD P3 and the P2 were associated with more clinical events of some kind, whether it's an infection or a surgical intervention or meeting criteria of decreased function or what have you. Whereas the P1 category did not predict increased risk. So I think we have some of that. It could be much better, no question. But I think the UTD does give us some idea of risk. It's crude, but it's better than nothing. It's a lot better than nothing.
Great, thank you very much. I'm going to switch to a different question, and last question for Armando, just in the interest of time. Do you or do your ultrasonographers find that corticomedullary differentiation on ultrasound is a useful parameter to pay attention to in children with the high-grade hydronephrosis?
So we haven't looked at that very closely when it comes to hydronephrosis, UPJ obstruction. We did look at it when we analyzed our data for posterior urethral valves, and that was one of the factors that was able to predict who will end up in renal failure. It's not that easy to measure, and it can be somewhat subjective. And perhaps I'm going to try to merge this a little bit with Caleb's answer to the previous question, which was brilliant, is that I think that we should risk stratify, but it has to be done in a way that it can be reproducible. And that's where the subjective things, what is decreased corticomedullary differentiation, and how do you measure that? And that's where I think that newer technologies like image analysis, machine learning, etc., it sounds like a buzzword, but actually may be where the answer is. Allows you to have something that is reproducible, that gives you similar answers, no matter where you are in the world. And that way we can at least stratify patients the same way everywhere. The SFU grade 1 and 2 and the P1s, yeah, those are degrees of hydro that even without a race stratification score, you can say this is going to be fine. The higher grades are the tough ones, particularly I struggle the most, for example, with the grade 3 hydro. What do you do with those, right? Those are the ones that can kind of go either way. So a better way to stratify, a more reliable way to stratify, I think is the way to go, certainly.
Okay. Well, I want to conclude this panel. Let me get back to that last slide. And here we go. And in particular, thank Armando and thank Caleb for fabulous presentations, a lot of food for thought. And as with any debate, always be tolerant of those who disagree with you. After all, they have a right to their ridiculous opinion. With that, I'll conclude the panel and hand it over to Dr. Paul Austin. Paul?